Last week, I sent a letter to all member states requesting them to join the vaccine arm of the ACT Accelerator. I'm pleased to announce that as of today, 172 countries are now engaging with the COVAX Global Vaccines Facility, which has both the largest and most diverse COVID-19 vaccine portfolio in the world. At present, there are 9 vaccines that are part of this dynamic portfolio, which is constantly being reviewed and optimized to ensure access to the best possible range of products. Even now, discussions are ongoing with 4 more producers, and a further 9 vaccines are currently under evaluation for the longer term. Most importantly, it is the mechanism to enable a globally coordinated rollout. This is in the interests of all countries, even those that have invested with individual manufacturers independently. We're working with vaccine manufacturers to provide all countries that join the effort timely and equitable access to all vaccines licensed and approved. This doesn't just pool risk. It also means that prices will be kept as low as possible. New research outlines that global competition for vaccine doses could lead to price spiking exponentially in comparison to a collaborative effort such as COVAX facility. It would also lead to a prolonged pandemic, as only a small number of countries would get most of the supply. As supply increases, the next stage of the vaccine rollout would be expanded based on an assessment of each country's vulnerability to the virus. A number of vaccines are now in the final stage of clinical trials, and we all hope we will have multiple successful candidates that are both safe and effective.
As it relates to SARS-CoV-2 infection among children, there's 3 things that we are looking at. And we're working with a technical advisory group that we have pulled together to help advise us. We're working with UNICEF, we're working with UNESCO, we're working with a number of partners to consolidate our understanding about this disease in children. First of all, what type of disease is caused in children? And so luckily, the vast majority of children who are infected with the SARS-CoV-2 virus appear to have mild disease or asymptomatic infection, and that's good news. But there are young children, there are children that can develop severe disease, and there are children who have died from infection. So if there's transmission that's happening in a community, it can enter into the school system. So what we really need to focus on is bringing transmission down in the school system. We have outlined guidance on how schools can reopen safely. Everyone agrees how important it is that schools are operating safely, and we've outlined how that can be done in terms of physical distancing and hand hygiene stations, respiratory etiquette, the potential use of masks by either the workers or the children themselves. And so there are a number of considerations of how the schools can be opened. But again, we really need to focus on reducing transmission in the community first. And so what we understand from the press release is that this may be an example of reinfection. And if you remember last week I was asked about this, and I had said that in cases like this it would be good if sequencing could be done. And in a place like Hong Kong, where they have very strong facilities, they can do that, and in fact they have done. I understand from the press release that there's 24 nucleotide difference between the first virus and the second virus. What I think is really important is that we put this into context. As you outlined in the question yourself, there's been more than 24 million cases reported to date, and we need to look at something like this on a population level. And so it's very important that we document this and that in countries that can do this, if sequencing can be done, that would be very, very helpful. But we need to not jump to any conclusions. To say even if this is the first documented case of reinfection, it is possible, of course, because with our experience with other human coronaviruses and the MERS coronavirus and the SARS-CoV-1 coronavirus, we know that people have an antibody response for some time, but it may wane.
So convalescent plasma therapy is actually something that's been used for over 100 years for various infectious diseases. And it's been effective in some and not so effective in others. So as far as COVID is concerned, again, this was one of the early therapies that was begun to be used. Essentially what it involves is collecting plasma from people who have recovered from COVID and then using it to transfuse into someone who's ill. And generally, it's been used in severely ill patients who've been hospitalized. There are a number of clinical trials going on around the world looking at convalescent plasma compared to standard of care. And only a few of them have actually reported out on results. And the results are not conclusive, I should say. That the trials have been relatively small, and the results, in some cases, point to some benefit, but have not been conclusive. And we've been tracking this, and we do ongoing meta-analyses and systematic reviews to see where the evidence is shifting or pointing. And at the moment, it's still very low quality evidence.